Good morning. We are taking off our masks as we are appropriately socially distanced. Hello, I'm Dr. Srinivasan, Director of Health First Aging Services. I'm board certified in internal medicine and geriatrics. I work with an interdisciplinary team of nurse practitioners, nurses, social workers, and pharmacists, and we specialized in care of older adults. We are unique in that we work with patients as well as their families to better understand their concerns and develop a customized care plan that meets their needs. I'm glad that you can join this panel discussion on mile markers during the journey of a caregiver caring for a loved one with memory loss or dementia. I will present a case study to illustrate the different stages of memory loss. We are going to discuss the concerns frequently asked by the caregivers during each stage. We welcome questions from the audience, and you can use the chat box to send in your queries. We hope to give you some tips for each mile marker to better prepare you and your loved one. Our panelists are Robin Petersen, elder law attorney, Michelle Rogers, Director of Home Care, Private Duty and Hospice, and Tiffany ORourke, our social worker. Without further ado, I'd like to welcome the panelists. Robin?
Yes, my name's Robin Petersen. I'm board certified in elder law, and I've been doing this specialty since 1990 and been certified since 1997. I work with other attorneys at the Estate Planning and Elder Law Center of Brevard. And my first fun fact, my first law job was as a legal officer in the Air Force, and I got to travel a lot. But now I stay in one place, Brevard County.
Hi, good morning. I'm Michelle Rogers, and I'll be representing Home Health, Private Duty, and Hospice today. I'm the Senior Operations Director for Health First and represent home care, and I'm excited to be here. Throughout the years, I've been in the home health industry for over 30 of them and lived in Brevard County and worked here for over 30 years as well. Really excited to be here today. I also serve on the Home Care Association of Florida board representing home care throughout the state of Florida, which has really kept me in tune with everything in the industry and what is going on today. Thank you.
Hello out there, everyone. I'm Tiffany ORourke. I'm born and bred in America's heartland right there in Iowa. I'm fortunate to have moved to Florida just a couple of years ago and joined Dr. Visa's amazing team at Aging Services. I have a bachelor's and master's degree in social work from the University of Iowa, go Hawks, and have worked all along the continuum of care with seniors and their families for almost 20 years now. I've worked in nursing homes, home care, hospice, hospitals, and again, I'm fortunate to be in the clinic setting today. I have a license in social work both here in Florida and also still in the state of Iowa.
Well, let's jump to the case now. I'm going to present John, who's 84 years old, married to Jane, 82 years old, and they've been married for 62 years. John has retired from the Air Force, and Jane is a retired teacher. They have a son who lives locally and a daughter who lives out of town. So family have been noticing some memory loss in Jane for the last year and a half. And they describe this as poor short-term memory. She's repeating herself, misplacing things, having some word finding difficulty. She's still driving very little because she's less confident, and she's not wanting to cook as much. She's making mistakes with the checkbook, but she's insisting that she is to manage the finances. She's sometimes forgetting to take her medications. And in terms of finances, she's also been scammed a couple of times. She's still able to shower herself, dress herself, and says that she's independent. John has had to start cooking, and he's not used to cooking, and that's becoming harder for him. And he's now keeping an eye on Jane's medications. She's afraid. Jane actually does not recognize that she has a memory problem. And the family are afraid to address this because they worry that she'll get upset. And now this is the first mile marker. When you have someone, either yourself or a loved one with memory loss, taking those first steps can be very difficult. And so we're going to discuss today some tips about how to approach this problem. So in our own practice, frequently they come to us after a year or so because they quite didn't know how to make that first appointment. And we usually tell patients or their loved ones that it's better to address it with the person privately, find an opportune moment. And many times you can address as a particular medical issue which is bothering them, not necessarily memory loss, but you bring up some other issue they're talking about so that it's more acceptable to them. So let's turn to Tiffany. So Tiffany, we see this a lot, right? So what kind of advice would you give families who are concerned about their loved ones' memory problems?
We do see this a lot. And I think one of the fortunate things about our service line is that we have social workers available to help families navigate that conversation even before that first appointment. And so I know we take phone calls all the time from families to help, how do I get my loved one to come? So as Dr. Visa said, do not lead with memory impairments. I think there's a lot of fear associated with memory loss and losing control and losing independence. And so finding something that's more acceptable for your loved one to see a geriatrician about. Maybe they're not sleeping as well as they used to sleep. Maybe they want to take fewer medications because we know as we age, sometimes we end up with a very robust list of meds. The other thing is to, remind your loved one that the intention is to maintain independence. Our goal as well as yours isn't to take away their freedoms or independence, but to put some things into place to help maintain their safety and their independence as long as possible. And my last tip is to enlist an influencer. We all know that there's someone in your loved one's life that perhaps can bend their ear in a way that you cannot. Maybe it's a trusted attorney, another family physician, a sister from Minnesota, whoever can kind of get involved in starting this conversation and encouraging your loved one to come to this appointment. Utilize that relationship.
So the next mile marker is what happens during the first evaluation. So during the first appointment, we do a comprehensive geriatric evaluation, which consists of a history, a physical, we review the medications, and we do cognitive assessment. We also assess function and mood. And what's unique about this assessment here is we do a psychosocial assessment, which includes advanced directives, legal and financial planning, and a diagnostic workup to look up for reversible causes of memory loss. And we confirm the diagnosis with a neuropsychological testing and come up with a care plan. So let's go back to Tiffany. Can you tell us what sort of issues you addressed during the initial social worker intake?
Yes, absolutely. So I tell our families and caregivers all the time how very different this evaluation and this doctor's appointment might be than any other one they've been to. That we really take our time to get to know them, their family, their needs, their concerns. And what makes Dr. Visa's team so unique is she does have, a whole bunch of folks that help with this, including 4 social workers. And so what we do is we evaluate some of the other things that might be impacting cognitive changes. So things like mood. It's not uncommon as we age that we might be more susceptible to things like depression. And by all means, depression certainly affects how we think and process and make decisions. Same sort of applies to social situations. As we age, it's often the case that we have kind of a shrinking social support, and those fewer opportunities to kind of interact with other folks can have an impact on our cognition. So part of what social workers do at our clinic is to try to have an impact on those things to improve cognition overall.
Right, and we also look at supports, what kind of supports they have or don't have. And an important, unique aspect of our evaluation is we spend as much time with the caregiver as we do the patient. In fact, I have a little saying that in geriatrics, I have 2 patients actually. I have the patient and then I have the silent partner, the silent second patient who is the caregiver. So what else do we do? So I'm going to turn to Robin and ask about what sort of planning do you advise seniors who want to age successfully?
Well, the planning ahead of time would involve an estate plan, meaning a will or a trust. Then you'd want to also put in place a durable power of attorney for finances and a healthcare power of attorney, also known as a healthcare surrogate designation. And if it's consistent with your philosophical and religious beliefs, maybe a living will that states you don't want to be kept alive artificially through medical means if you're in a persistent vegetative state or terminal condition. Those would be the bedrock foundation, just generally speaking.
So frequent questions that come up, Robin, is there a difference between power of attorney and durable power of attorney?
I probably have done one or two basic powers of attorney in my life. I've done, professional life, thousands and thousands of durable powers of attorney. I don't know why somebody would do a power of attorney without making it durable. What's the difference? Durable power of attorney is effective even upon the incapacity of the person creating it. So a general, normal power of attorney that's not durable would cease to be effective, so that the financial affairs of the incapacitated person could not be handled by the agent that they've named if it were a non-durable power of attorney.
So Michelle, we hear a lot about skilled services and home care, and especially now with the pandemic raging and everybody is afraid to let strangers come into the house. Can you give us a little bit of understanding of the scope of services of home care and skilled services, and if any special accommodations are being or precautions are being followed for the pandemic?
Absolutely. Thank you. It has been a very scary time for all of us, and particularly in the home care industry. And when patients have someone come into their home, we want to make sure that we are taking every precaution to keep our patients and their family members safe. Health First Home Care and Health First Private Duty were some of the first in the county to be able to accept the COVID positive patients. And in doing that, whenever we do care for them, there's a separate specialty team that cares for patients who are positive, and then another team who cares for other patients. They are protected with plenty of personal protective equipment. We were very fortunate at Health First not to have any shortages. So between our mask, our gowning, our goggles, everything that we put on as from a caregiver or a clinician or professional standpoint when we go into the home is how we keep our patients safe. We also ask that our patients and their family members wear a mask if we're in close proximity. Sometimes the functions they're performing are very close and less than 6 feet, and that's where the extra precautions come into place. But then if they're doing possible things like housekeeping or other chores where they're distant, then they would be able, if everyone is in agreement, to remove their mask. So it has been a very tenuous time, but we've taken every precaution to make sure that at Health First we are safe whenever we go into someone's home.
That's reassuring. So Tiffany, in this situation, in this case study, Jane has been diagnosed with mild Alzheimer's dementia. So when it comes to somebody with mild dementia, can you just advise caregivers as to what sort of planning should they do in terms of safety?
Absolutely, absolutely. So this is probably going to be the time where we're going to start suggesting some supported decision making. Now, this does not mean I'm going to ask husbands or wives or daughters and sons to jump in and take over things, but to start being included in some decision making and helping their loved one make their own independent decisions. So as we know, as this disease progresses, folks are going to have gradually more and more problems with complex things like managing their finances, taking their medications, driving a car. So this is where you're going to hear us say, maybe take a peek at mom's med planner every week. Does she appear to be taking her medications? Maybe ride with dad once or twice a month. Does he appear to be able to manage the rules of the road? Again, these conversations need to include your loved one so that they continue to sort of lead the charge and be in charge of their life, but you're there to support them. We also suggest at this point caregivers start building their team, right? Building a network of helpers, or like Dr. Coyle says, your lifelines. The other people that you're going to lean on and turn to, perhaps it's the folks from Health First Home Care that are going to step in and help. But to start putting a network of people together before there's a crisis, because I assure you planning in a crisis is very, very difficult. There's also supports available through the Center for Family Caregivers. I know myself and John Casso, another social worker at my clinic, are running 2 virtual support groups every week. So starting to connect with that network of helpers. Getting those lifelines in place is my first suggestion at this stage.
So coming back to this case study, we know Jane was diagnosed with mild Alzheimer's dementia, and John is the main caregiver. So John is 84 himself. He has multiple medical issues. He's hard of hearing, which makes it difficult. He gets really irritated when he cannot hear what Jane is telling him. And Jane keeps repeating the same thing over and over, which really stresses out John. He's very irritable. He's lost weight. He does not want to ask for help. He's been having frequent falls, and one of those falls led him to be admitted in the hospital, where he had multiple complications. So as Dr. Coyle mentioned, the caregiver is under tremendous stress, and this can decrease their immunity and make them more vulnerable to infections and hospitalizations. So Tiffany, can you just tell us what are the signs that caregivers have to look for to know that they are under stress?
Absolutely. And I think Dr. Coyle pointed some of them out. So I find caregivers starting to be maybe a little more irritable, right? Having a harder time kind of staying calm and managing their mood and rolling with the ever-changing, environment that caregiving is. I also hear them time and time again tell me about how they've put their own needs on the back burner to take care of their loved one. So they've stopped going to the doctor. They're not eating well. They're not exercising. They might not even be sleeping. And so I tell my caregivers time and time again, and as cheesy as it sounds, it's true. You cannot pour from an empty cup. If you yourself end up sick because the stress has overwhelmed you and you haven't sought help, that's only going to complicate the situation you have at home when you're trying to take care of a loved one. And depression is very common. Something like 50% of caregivers have to seek out their own supports for depression. Just know that a combination of talk therapy, medication, and some lifestyle changes are going to be necessary for a successful caregiver.
So those are some important tips, and we have a lot of resources here in Health First, including the support services and activities at the Center for Family Caregivers. So coming back to Jane, she's been getting more forgetful, and now she's needing reminders to shower. She forgets to change her clothes, and daily activities are becoming more difficult, and she's needing more assistance. At this point, when patients get into moderate stage of dementia, they have something called sundowning, and many caregivers usually bring this up during the visits. Sundowning is confusion that starts in the late afternoon that spans into the night. And patients can have different ways of presenting. They'll have changes in mood and personality where they become more anxious, more repetitive. They have restlessness. Sometimes they get agitated. And some patients can also have hallucinations and delusions in the evening. And this can make it much more difficult for the caregiver, who themselves are tired at the end of the day, to be managing this. We don't exactly know why it happens, but some theories are that it's at the end of the day, the brain is tired, there's low lighting, maybe the patient is fatigued, there's no structured activities, and these are the common causes of sundowning. So, Tiffany, can you suggest some tips for helping with sundowning, both for the patient and the loved one and the caregiver?
Yes, absolutely. So, oftentimes it's the non-pharmacological things that we do that tend to be more impactful for our loved one during these, challenging evening hours. The first suggestion is to get out a notebook and start logging behaviors. See if you can find a pattern. Perhaps it's right around 2:30 every day, like clockwork. You find your loved one is up and wandering and getting a little more confused. Perhaps it's while you're making dinner. Start logging them and see if you can find the pattern, because then what you might be able to do is avoid that time of day by changing your routine or engaging your loved one in some kind of relaxing activity before they start to have a hard time. My other suggestion is to routinize your day. Establish a very structured routine. And this is good for all of us, myself included. Have breakfast around the same time every day. Have lunch around the same time every day. Plan outings and activities at the beginning of the day and slowly kind of wind down across the evening hours, giving your loved one a chance to kind of relax as the day goes forward. Things like leaving the lights on tend to help. There's something about the actual sun going down and it getting dark that often triggers this agitation. So turn the lights up. Turn off the TV. Again, we should all do this also. Turn off the TV a couple hours before evening time. Turn on soft music. Have a warm bath. Whatever you can do to really wind them down tends to be very successful. And always remember the possibility of an underlying condition, like a UTI, for example. So if you notice a sudden behavior change, please do seek out a medical evaluation.
And so in this situation, John is really stressed, and there are some other supports that you can use to decrease the sundowning. As Tiffany mentioned, if the person is kept active during the day, that can actually reduce their chances of having sundowning in the evening. So in that regard, sometimes you can hire people to, or services. And let's talk to Michelle about that. So private duty and respite services, how do they help our loved ones, and how do they help the caregivers decrease stress?
Sure. The caregiver that does get so tired, and especially if they're up at night, that's when it really takes its toll. So there are several opportunities for care in the home. There is home health care, but there's also private duty and respite. And that respite gives you a few hours a day, several hours a week, or even round-the-clock care, depending on how the illness is progressing. So when that caregiver comes in, they can help with everything from personal care, bathing, dressing, light housekeeping chores, meal preparation, or sometimes if that family member or that primary caregiver, for instance, if John is a golfer, I believe, if he wanted to get out and still be able to be active when he's golfing, he could have 4 hours a week where he could just get out of the house, and that just provides a little bit of respite that re-energizes you and keeps you going.
So Michelle, who pays for this? Does insurance cover these services?
For private duty care is usually generally not covered by any of our regular insurances like Blue Cross Blue Shield, United. It's considered custodial care is what they call it. So unless you have a long-term care policy, which many do, it would be out of pocket.
So when it comes to out-of-pocket expenses, a lot of our seniors live on fixed incomes. And here, luckily, John is a veteran. So Robin, can you tell us about veterans and what sort of assistance they get?
Sure. I was able to get veterans aid and attendance for both my parents. They were World War II vets. And that's basically, I could do a whole seminar on this, but it's a needs-based program for veterans who served during wartime. And, it could be 30 days during a declared war. And that veteran does not need to have left the United States even, or have served in a theater of war. There are some other qualifications such as asset and income tests. But there's money that would be available anywhere from about $1,100, $1,200 a month up to about $3,000 a month.
Yeah, and this is actually very helpful for a lot of our patients. I think this is, the VA aid and attendance is not just for veterans having the memory problem, it's also for their spouses, right?
That's correct. It's for unreimbursed medical expenses.
Okay, that's an important thing to remember.
By the way, that can include skilled nursing facility, assisted living facility, home health care.
So
it can be any regularly recurring unreimbursed medical expense.
So that's important to remember, that it can be in different settings of care. So the other things that can help decrease caregiver stress and also sundowning is use of other services like adult daycare, perhaps. Can you talk a little bit about that, Tiffany?
Yeah, absolutely. So when I talk about finding care for your loved one, I usually present that you have to bring the care to your loved one, like through in-home care services, or you have to bring your loved one to where the care is. We're very fortunate in Brevard. We have a number of really spectacular adult day programs. So these are places where there is staff to support and supervise your loved one during the day. They are engaged in meaningful activities, meals are provided, personal cares, bathroom showers, those kinds of things all can be taken care of while you are taking that 4-hour break to go golfing. Maybe you still work, or you just need a couple hours in the middle of a Wednesday to just be alone in your home and kind of reset. So again, bringing your loved one to the care can be sometimes a little more affordable, or just another option as you're kind of patchworking a good respite plan together.
So let's come back to John. So John comes back from the hospital. He's very weak. And remember, he had a fall, so he's needing to have physical therapy. So this is part of the skilled services. And so, Michelle, can you talk to us about Medicare? What kind of skilled services does Medicare provide for people at home?
Absolutely. So whenever you're getting Medicare skilled services, there are some caveats that you're looking for that kind of trigger that with your physician. So your physician is going to order that skilled care in the home. And it is a huge relief, again, for the caregivers. You can have skilled nursing, physical therapist, occupational therapist, speech therapist, as well as a home health aide that can assist with that care. And so a plan of care is designed between the clinician that comes out into the home with the physician and the family in mind, and based on what we're trying to accomplish in the home and what we're looking to do. That's how that care is laid out and designed in increments. You may have all of those services at once or just one of the services, and that's the beauty of it. And it is reimbursed by your Medicare pays for it.
And in case of John, remember he had multiple falls, so home care actually also had an occupational therapist come and do a home evaluation, a home safety evaluation, and the social worker actually came to the house and advised John to have a personal emergency response. So what is the personal emergency response, Tiffany?
Sure. It's a wearable device. I think we've all seen the commercials, I've fallen and can't get up. But it's something that your loved one would wear either maybe around their neck or on their wrist, and any moment, day or night, for any kind of emergency, medical or otherwise, they could press the button and get help. Certainly an advisable thing for any and all of our seniors, especially those that are living alone.
And so Jane, as we recall, insisted on managing her finances, and now she's giving away her personal information. And it's come to the point where they've lost thousands of dollars. And we see this a lot of times in our patients. And then the family wants to protect the assets, and then they want a letter of capacity. So, Robin, what is the difference between capacity and competence? Can you explain to us?
Well, I can. What I'd like to do is I'd like to say, in a legal setting, all of us have a presumption of capacity, unless a court takes it away through a process known as guardianship, and there would be a finding of incapacity. Is that kind of what you're getting at?
Yeah. So, what is guardianship, and what does that entail?
So, guardianship. Well, guardianship is the court supervision of incapacitated person's affairs. Affairs meaning medical decisions and financial decisions. We talked very briefly earlier about a power of attorney for finances and a power of attorney for healthcare decisions. Those can avoid guardianship, and they're very cost effective compared to your typical guardianship, which runs, if it's very straightforward, it runs $9,000-$10,000. There's a lot of people involved and a lot of reporting to the court involved. So the guardianship process for an elderly incapacitated person would last their entire life. And that's it in a nutshell. There's more to it than that. But.
So when people get their legal papers in order, is it enough for them to have a durable power of attorney for finances? Or do they need like a pre-need guardian?
Okay. A pre-need guardian designation states, okay, I'm doing the power of attorney for finances and healthcare, but if for some reason they're not working because I'm being exploited or I'm self-neglecting, then I want this person, usually a family member, to be my guardian in the court proceeding. if the advanced directive of power of attorney and healthcare power of attorney is in place, there's a very small chance, percentage-wise, that a guardianship would be required. But in dysfunctional families, kids are jealous of each other, or there's just sibling rivalry, or kids against second spouse, frequently a guardianship would be required, and it's nice to be able to nail down who you want in charge, nail it down ahead of time when cool heads prevail, and there is capacity on the part of the parent who's making the decision, the elderly person who's making the decision.
Yeah, I think as a group we can agree that preventing guardianship is better. And the best way to do it is planning ahead of time and having all the papers, which brings me to the next question. So frequently I have people moving down from north to here to settle. And when they come for the first visit and we ask them, they say they have all that papers, but it was done 20 years ago out of state. So what should our advice be to these people?
Okay. In Florida, we have a very stringent requirement for powers of attorney. I have never seen a power of attorney outside the state of Florida that I can recall anyway, that fit the criteria for the Florida power of attorney. It's very comprehensive. If it's not in the power of attorney, you can't do it, and there needs to be specific authorizations of about 8 or 9 different areas with initials next to each of those specific authorizations for the power of attorney to be as effective as it should be. Also, 20 years ago, Florida had a completely different power of attorney law. So if a power of attorney was created before 2012, I should say, October of 2011, it's probably not going to be effective in Florida, even if it was done by a Florida attorney. So, and if they're moving down from out of state, we look at those documents to verify whether or not they'll work. Healthcare power of attorney, it's a little more universal. Florida's not so specific about that. And then the wills and trusts coming down from out of state, it should be reviewed to make sure it fits the Florida requirements. Because if it doesn't, no one's going to be happy, your heirs especially.
So what happens to Jane? Also, the dementia progresses, and now Jane requires around-the-clock assistance with daily personal care. She's starting to have swallowing problems. She's becoming very unsteady, and she's getting frequent urinary tract infections. So this is the advanced stage of dementia. So when people come to the advanced stage and they near the end of life, we talk about hospice. So hospice services in terms of meeting criteria, Medicare criteria, can be a little difficult for families to understand, because unlike cancer, where the cancer is spread at stage 4, then we know the life expectancy is less than 6 months, it's not so easy to prognosticate as the dementia progresses. So typically, if dementia is the main diagnosis for hospice referral, the patient should be at the end stage. They should be unable to ambulate without assistance. They pretty much require care for all activities of daily living. They have barely meaningful speech. They are doubly incontinent. And not everybody has all of these, but we talk about palliative care and hospice when we have other things. So by the time somebody is progressing to the advanced stage of dementia, we also look at other comorbid conditions. Maybe they have end-stage heart failure or COPD, or they are losing weight, or they've been twice to the hospital in the last 6 months with pneumonias or urinary tract infections. So when they have all of these things going, I think it's very, very reasonable for families to approach their physicians to talk about hospice services. So Michelle, can you explain to us what hospice services covers and what caregivers should know about hospice?
Absolutely. So when you're talking about hospice, the word sometimes is very intimidating for families, but I've been able to use hospice myself for family members, and working in the hospice settings, there are so many opportunities for additional care. It becomes more curative at that point, where you're looking to provide comfort and you're working with a physician and a team that actually supports anyone who is having hospice services. There are nurses, social workers, physicians, nurse practitioners, aides, chaplains, music therapists, volunteers. So there's a myriad of people who you can use as resources to help take you through this process. And it is to keep your loved one comfortable at home, but the support that it provides for the caregiver, I think, is also one of the main points here. As we've talked about through the whole process, hospice particularly focuses on not only the patient themselves, but also the caregiver, to be able to support them through this process.
And again, the goals of care is to keep the person in their own home. So 70% of patients with dementia, they are cared for by family, friends with support services at home. But sometimes the care needs of a person may exceed what can be provided by the caregiver at home. We see situations where the caregiver is an elderly spouse, or maybe adult child, son or a daughter who's still working, who's the sandwich generation. And then they talk about perhaps moving their loved one to a place that can meet their needs. So we call this placement. And this is where a lot of confusion arises. So Tiffany, can you give us some sense of what transition tips do you give for families considering placement, and how do you dispel the myths that if somebody is taken out of their home, they only have the nursing home to go to?
Sure. So placement, of course, is a really kind of emotionally challenging thing for most caregivers. Some of us might feel like this is a place where somehow we've given up, or we just can't do it anymore, and we've failed as a caregiver. And so it's important to sort of, tap into what you're feeling emotionally as you start down this process. Now, in some situations, we have a lot of time. Placement is a process. There are so many kind of working parts, from the type of place your loved one might go to. It isn't necessarily just a nursing home. It could be an assisted living home. It could be a small family home. We have lots of those here in our county. There's the financial pieces, who's paying for what? Maybe the VA aid and attendance has been tapped into, and we want to use those supports. So if there's time, this is something that happens sort of slowly. We kind of put our ducks in a row. We find the places, we tour places, we invite mom to come with us to look at places. All the financials are in place. But it isn't always like that. I can't tell you the number of times that we get calls at our clinic, caregivers in crisis. They've hit the wall. They're just ready to explode. They can't take it anymore. They need the break, and placement needs to happen right now. And so that's why Dr. Visa has this whole robust team of people to help her. And so we take those calls in the midst of crisis. We help families kind of navigate what are our options today, what are our options tomorrow, and put some things in place. I say to a lot of my caregivers, we put plans together with duct tape and super glue if we have to get through the next 24 hours or the next 72 hours and into the next week if we need to. So lots of moving parts. Just know that there's support.
So which brings me to the next question. A lot of times people consider placement either when the hands-on care is more than what they can meet, or if there's behavioral issues, right? Like hallucinations or delusions, or somebody's constantly repeating, saying the same thing, and the caregiver says, I can't deal with this anymore. So this is where just one word of advice. If you hear your loved one constantly saying the same thing, the tendency is to correct them, or the tendency, the common things I hear with sundowning is they are ready to packing up and they want to go home even though they are at home. Or perhaps they don't recognize their husband, and the wife can ask the husband, where is my husband? So if you see these kinds of repetitive behaviors, I always tell this to my caregivers, after the first 2 times that you hear with your ears, start hearing what they are saying with your heart. In other words, listen to the emotion behind the words. And don't answer back in words and correct them and confront them with reality, but validate how they feel and respond to their emotion. So if somebody says, I want to go home, and they're still at home, don't say, this is the house we purchased, here is the deed, and things like that. Instead, you look at the emotion behind the words. The emotion is confusion. So your response should be reassurance, telling them they're safe. So there's actually a whole 1-hour talk we can talk about, how do you redirect the person and how do you reassure the person. So because of the constraints of time, I'm now going to switch to end of life and DNR. That's something that comes up all the time. Do not resuscitate. So for most people who have advanced directives, the do not resuscitate comes as a part of it. But in the state of Florida, a special yellow form needs to be completed. So there's a lot of confusion about do not resuscitate, and it can be an emotional decision to complete that form. But if they already have advanced directives or are living, we'll just look at what they wanted, and you want to make sure that their wishes are being followed. And remember, when we say do not resuscitate, we are not saying do not treat or abandon. All we are saying is do not do heroic measures if you know that there's going to be no meaningful recovery from whatever happens that that necessitates resuscitation. So with that, I think we tried to hit the highlights of the different mile markers. So I'm going to end the session with take-home messages from all our panelists. My own take-home message is memory loss is not a normal part of aging, and not all memory loss equals dementia. So if you or a loved one have concerns about memory, please discuss with a trusted family member or friend and seek help from a doctor, and make sure that when they go to the doctor, they have someone else with them. There are lots of things that could be causing these changes, and dementia may or may not be one of them. So the sooner we know what's causing these problems, the sooner we can address them. And my last thought is, please make sure that you get your flu shot and pneumonia vaccine, and follow the CDC guidelines of social distancing, wearing a mask, washing hands frequently with soap and water for 20 seconds, and avoiding social gatherings. Robin?
What I've seen over and over and over again in 30 plus years of doing this is getting your ducks in a row before a crisis just makes sense. The peace of mind, I can't tell you how many times I've heard a client tell me they're walking out the door, they've got their documents in place, and they're going, I can't believe how much peace of mind I have. And I'm so glad I did this. It's much better to think about it rationally than in a crisis situation.
So the takeaway I'd like to leave you with today is there is help. And as you heard from the resources that we have in a continuum of care for each step of a progression of a disease process, there is someone there to assist you, whether that's working with your physician and support services through private duty home care, through getting the right equipment in the home, just planning those stages. We, for Health First Home Care, Health First Private Duty, Health First Hospice, we can come to your homes and we can meet with you, and we can sit down and we can have those conversations ahead of time. We even have pre-registration opportunities where you can pull triggers later if you need to at any given time. The thing is, we just want you to know that we are there to support you, and that is the main thing. If you don't take care of yourself, you won't be there to be able to take care of your loved one.
Great. So my takeaway is that even though sometimes it seems easy to focus on the challenging parts of caregiving, you know, the downs and the hard days and the tough times, there's also overwhelmingly positive aspects of your caregiving role. Caregivers tell me over and over again that they feel useful, that they're needed, their life has meaning, that they've developed a closer relationship with their loved one, that this has become an opportunity to care, not a burden to care, that they've learned to appreciate the littler things and let go of things that they can't control. And it's been a really growing opportunity for most of us. So 2 things: remember to keep your cup full, right? Because you can't pour from an empty cup. And 2 is you do not have to do this alone. Remember the dog in Dr. Coyle's picture at the very beginning? Sometimes you're stuck in a tree and you can't get out without help, and it's okay to get the help.
So thank you all for joining this discussion. We will now have Dr. Coyle discuss tips and tools to manage caregiver fatigue. Thank you all.